So welcome to the first lecture for Principles of Epidemiology. Today we will be covering a general introduction to epidemiology, the historical context of epidemiology, descriptive epidemiology, and measures of disease frequency. If you have not yet listened to the posted recording covering the introduction and expectations of this course, please do so before proceeding with the first lecture. So what is epidemiology? Epidemiology is an information science. Epidemiology generates data for decisions made at the level of the community or the individual practitioner about investigating problems or prescribing appropriate interventions. In the broadest terms, epidemiology involves describing and interpreting the patterns of disease occurrence in populations in an effort to apply this knowledge to prevent disease and alleviate human suffering. Therefore, almost all of epidemiologic studies are based on the concept of attempting to identify all cases of disease in a defined population at risk. Because disease is not randomly distributed in populations, we can look for measurable factors that influence the pattern of disease and the underlying causes of disease. In descriptive epidemiology, we are attempting to describe the patterns of disease within or across populations, so the who, what, when, and where of disease. In analytic epidemiology, we are attempting to examine the factors that influence the prevention, occurrence, control, and outcome of disease. We use epidemiologic information to plan and evaluate strategies to prevent illness and to guide the management of care for patients who have already developed disease. So what is epidemiology? Epi can be viewed as both a field of research to advance scientific knowledge and understanding, as well as an application of knowledge to solve public health problems. Epidemiology typically involves a multidisciplinary approach to both research and problem solving. Regardless of whether epi is a field of research or an applied practice, it is always concerned with populations. A population is not defined by a fixed standard number of individuals, but is defined by the specific group under study. Your population may be large and diverse, for example, all persons living in the United States, or it may be small and homogeneous, for example, all women giving birth at St. Mary's Health Center. Frequently, populations are defined by geographic boundaries, for example, residents in the city of St. Louis. However, populations may also be defined by more specific demographic characteristics, or by political, governmental, or organizational units. Subpopulations are the basic unit of comparison in epidemiology. The risk of acquiring a disease is studied across subgroups within a population. For example, in a managed care environment, knowledge of health and risk of disease across subpopulations provides information for the estimation of prevention and treatment costs. Milton Terrace recognized four main functions of epidemiology. These are to discover the agent, host, and environmental factors that affect health in order to provide the scientific basis for the prevention of disease and injury and the promotion of health. To determine the relative importance of causes of illness, disability, and death in order to establish priorities for research and action. To identify those sections of the population which have the greatest risk from specific causes of ill health in order that the indicated action may be directed appropriately, and to evaluate the effectiveness of preventive and therapeutic health programs and services in improving the health of the population. Data generated with epidemiologic methods may be critical for a number of decisions. Armenian and Shapiro list areas for decisions that need epidemiologic information. Epidemiologic methods can be used to assess the efficacy of a treatment as well as its effectiveness. Efficacy refers to whether or not the treatment works under the best circumstances, while effectiveness refers to whether or not the treatment works in a real-world setting. Epidemiologists are also involved in assessing compliance or adherence to prescribed regimens, as well as evaluating quality, planning and programming, monitoring and evaluating, and community diagnosis of the presence, nature, and distribution of disease. So epidemiologic research typically, though not always, is observational rather than experimental. It focuses on free living human populations defined by geography or some demographic characteristic, which could be occupation, migration status, health conditions, exposure history, etc. rather than a group of highly selected individuals studied in a clinical setting. And it frequently takes a multidisciplinary empirical approach directed at understanding or solving a problem. So EPI as a multidisciplinary field frequently draws from biostatistics and the social and behavioral sciences, as well as from the medically related fields of toxicology, pathology, virology, genetics, microbiology, and clinical medicine. Quantification is a central activity of epidemiology. So epidemiologic measures often require counting the number of cases of disease to quantify the size of the problem. We also examine disease distributions according to demographic variables such as age, sex, and race, as well as other variables such as exposure category and the clinical features of a disease. Epidemiologic reasoning begins with a suspicion that a factor influences disease occurrence. This can arise from information from clinical practice, lab research, by examining disease patterns, or by examining prior epidemiologic studies. The next step in epidemiologic reasoning is to formulate a specific hypothesis. Next, we will conduct an epidemiologic study to look at the relationship between an exposure and disease. Within the framework of epidemiologic study, we must consider chance, bias, and confounding when interpreting study results. We will cover each of these concepts in depth over the course of the semester. The final step in epidemiologic reasoning is to judge whether an association is causal. We will also cover causality later in this semester. To understand a condition or event, we need to understand where it came from. Therefore, it is important to explore the history of epidemiology before examining the field as it currently exists. There are a number of events that led to the development of modern epidemiology. Your book does an excellent job of elucidating each of these examples, so instead of walking through each of them here, I will let you read more about the examples and move on to a historical timeline by Schoenbach and Rosenman. Schoenbach and Rosenman give a timeline for the history of public health and epidemiology from antiquity to today. We do not need to go through each individually. However, I will highlight some of the biggest and most often cited contributions to the field. Roughly stated, the history of epidemiology can be divided into three somewhat arbitrary time periods: early epidemiology from the 5th century BC through 1830, classical epidemiology from around 1830 to the 1940s, and new or modern epidemiology from the 1940s through the present. In antiquity, Hippocrates developed a medical approach by describing actual clinical cases of disease and linking disease to environmental factors. He was the first to suggest that disease might be associated with the environment. It also represents the first movement away from supernatural explanations of disease causation. John Grant recorded seasonal variations in births and deaths, as well as gender differences in mortality. Bernardino Ramazzini influenced understanding that disease can be related to occupation and to shared work circumstances. Edward Jenner developed a method for smallpox vaccination after conducting an experiment to determine if inoculation with cowpox would prevent acquiring smallpox. And Pierre Charles Alexander Louis utilized rigorous comparative methods to evaluate the effect of bloodletting on mortality. A great example of the move towards systematic examination of disease causation. In the early 1830s, we move into what can be considered the time period of classical epidemiology. The industrial transformation of Western Europe contributed to the development of crowd diseases in the slums of industrial developments. It was at this point that observational epidemiology began to take shape. William Farr established a national registration system for the collection and analysis of mortality statistics, the forerunner of today's vital statistics and disease surveillance system. Ignaz Semmelweis observed higher mortality rates among women on the teaching wards for medical students than on the teaching wards for midwives. He noted that the midwives washed their hands, whereas the medical students did not wash their hands. After introducing the intervention of hand washing in the medical wards, the mortality rate was reduced to that of the wards staffed by midwives. Finally, John Snow investigated cholera outbreaks in London. Snow believed that the source of cholera was contaminated water. Using what we know today as shoe leather epidemiology, Snow collected data on cholera deaths and the water supply. He demonstrated that there were more deaths from cholera in areas where people received water from two companies using a polluted part of the Thames River, compared to those receiving water from a company located farther upstream in an unpolluted portion of the river. Snow was able to demonstrate the waterborne nature of cholera through observational data. As we reach more recent epidemiologic history, we can observe successes in epidemiology's influence in public health, including fluoridated water, tobacco control, and toxic shock syndrome. So here you can see John Snow's findings from his descriptive study of cholera. John Snow's achievement was based on his logical organization of observations, his recognition of a natural experiment, and his quantitative approach to analyzing the occurrence of disease in a human population. So we can describe 7 uses for epidemiology. These 7 uses are broken down into 2 general areas, those related to health status and health services, and those related to the etiology of disease. Under the health status and health services uses, epidemiology is useful for describing the occurrence of disease in the community, for planning allocation of resources, and for evaluating health programs and services. In the area of disease etiology, epidemiology is a method used to search for clues as to the nature of disease and to use this knowledge to prevent the occurrence of disease. In descriptive epidemiology, we attempt to identify the distribution of disease, typically using vital statistics or other available data. We are concerned with the person, place, and time of the disease. Person refers to the demographic characteristics. Who is being affected? Are they old or young? Are there racial differences in disease distribution? Place refers to the geographic distribution of disease. Are people in rural areas more likely to be affected than urban? Is the distribution different by state? Time refers to the chronology or history of the problem. So has the incidence of the disease been increasing or decreasing? We want to know who has the lowest or highest disease rates in the population. Do disease rates differ by age, gender, race, ethnicity, socioeconomic status, marital status, occupation, or other person factors? When we're discussing place, we're concerned with the lowest and the highest disease rates for a population. So do rates of disease differ by geographic location? Is there a difference between urban and rural areas? When populations move to a new location, do their rates of disease change? For example, in Japan, there's a low rate of colon cancer. However, within one generation of moving to the United States, the Japanese rate of colon cancer is the same as whites within the U.S. When we're concerned with time, we want to know if the disease rates are changing over time for the population. We tend to see short-term trends with infectious diseases, long-term trends for chronic diseases, and we might see cyclical trends. For example, the flu tends to be a seasonal illness, or other sinusitis that might be associated with allergies is often seasonal, and we see cyclical trends. Diagnosis in clinical practice is very different from an epidemiologic diagnosis. In clinical practice, the clinician is typically interested in diagnosing an individual based on all the relevant information, the patient history, the signs and symptoms, the laboratory tests. It is typically a complex process with the ultimate goal of improving clinical treatment and restoring health to the patient. In epidemiologic research, we are not concerned with the diagnosis of an individual patient in order to provide an appropriate treatment. Instead, we are concerned with finding an appropriate case definition that ensures that every person in the study that we designate as having an illness truly has that illness. Because we are concerned with populations, not individual patients, the diagnostic definition needs to be as simple as possible to ensure the appropriate people are included, while others without the disease are excluded. Researchers frequently do not have access to the subjects to complete a medical history or complex laboratory tests. Therefore, they must make sure that their diagnostic definition is easy to measure. A case definition is a way to describe who has the health-related state of interest by identifying the who, when, and where. It is a set of objective, uniform, and consistent criteria by which to decide whether an individual should be classified as having the disease under investigation. Case definitions are composed of the clinical criteria and other restrictions based on the person, place, and time characteristics described earlier. The case definition should be specific and unambiguous, and it should be applied consistently without exception throughout the study. For example, the National Center for Health Statistics created a case definition for current adolescent alcohol use when developing the questions for the National Health and Nutrition Examination Survey, or NHANES. In this study, current adolescent alcohol use was defined as an adolescent ages 12 through 17 years old who had at least one drink of alcohol within the 30 days prior to the survey.